Good evening everyone. I am Dr. Arvind Arora. I am an orthopedic surgeon. I write books for various PG entrance examinations as well as for individual subjects. I also teach orthopedics for final year MBBS students as well as students who are preparing for their PG entrance examinations. Right now, I am taking online classes on Unacademy platform, which is now the largest learning platform for live online classes. Here on this platform, this prep ladder is also under the umbrella of Unacademy. For this dual benefit, we have iconic subscription, where you will get the benefits of both, that is recorded lectures of prep ladders as well as live online classes of Unacademy. Welcome Dashrath beta, welcome, good evening for Unacademy. And here are the subscription charges for iconic subscription. For live online classes for plus subscribers on Unacademy platform, we have very well structured courses where top educators are teaching all 19 subjects in a very comprehensive and understandable way. So if any one of you want to subscribe any of the subscription types of subscription, here is my code DRARVINDYT to get 10% instant discount. So now we will start some of the MCQs. These MCQs are very important and most of you have attempted all these MCQs, but no matter how many times we attempt these MCQs, some of us, not all, some of us are always getting confused again and again. Okay, so that is why I have taken out all those MCQs. These are mostly clinical and image based MCQs. Okay, so let's start. A patient came with complaint of difficulty in climbing upstairs. When he is made to stand on his left leg, right-sided pelvis fell to lower level. When he stands on right leg, then left side pelvis can be drawn up. Affected nerve is right inferior gluteal, right superior gluteal, left superior gluteal, left inferior gluteal. Yes? What is the answer, beta? Dhritarashtra, beta, what is the answer? Anyone? Dhritarashtra is saying D. Anyone else, beta? Okay, so here the examiner is asking nothing else but the Trendelenburg test. Okay, so we are talking about Trendelenburg test. So first we will see how we do this test, because this test is very important for all exam, FMGE, K.E.M, All India NEET. Okay, so there are so many questions which have been asked from this Trendelenburg test. First we will see what is this test. So in this test, we stand or sit behind the patient, on the back side of the patient, and we ask the patient to stand on one limb. Now what happens normally, because this limb is in air, so due to gravity this side pelvis will try to come down, but to prevent that there will be reflex contraction of abductors on the standing limb. Okay, so this abductor will contract and it will prevent falling of pelvis on this side. Okay, so pelvis will not fall on this side, either will be stationary or it will go up. So this is normal person. Okay, it is in normal person. Now imagine if this abductor mechanism is defective, it cannot lift this pelvis like this. So what will happen? In positive Trendelenburg test, the opposite side pelvis will sag down, it will come down. So this test is for checking the abductor mechanism of standing limb. Abductor mechanism of standing limb. Now what are there in all these abductor mechanisms? Okay, it is not only the muscles or nerve. What are the components? The fulcrum around which movement takes place is hip joint. Lever arm on which the power will act is head and neck of femur. And finally, there should be some power for the movement that is provided by abductors. And the major abductor around hip joint is gluteus medius, which is supplied by superior gluteal nerve. Okay, so now you can see if there is any pathology in hip joint like development dysplasia of hip, Trendelenburg test will be positive, or any defect in lever arm, head and neck like fracture neck femur, or destruction of head like in Perthes disease or avascular necrosis of femoral head, or there is some problem in abductors, paralysis of gluteus medius due to poliomyelitis or injury to superior gluteal nerve. So these are the important causes of positive Trendelenburg test. So what is positive Trendelenburg test? When there is defect in abductor mechanism, the opposite side pelvis will sag down. This is positive Trendelenburg test. Positive test means there is some problem in abductor mechanism on the standing limb. Now see the question once again. Now the patient is asked to stand on left leg. When the patient is standing on left leg, right-sided pelvis is falling down. That means left-sided abductor mechanism is defective. If left-sided abductor mechanism is defective, it is left superior gluteal nerve which is injured. Okay? On standing on right limb, left side pelvis can be drawn up. That means right-sided abductor mechanism is normal. Okay, clear to everyone, better? So now I will give you quick recap of this Trendelenburg test. It is done for abductor mechanism of hip. Normally, in normal person, on standing on one foot, the pelvis of opposite side will be pulled up by abductors. If there is some problem in abductor mechanism, that is positive test, the opposite side pelvis will drop down. Now, the test can be positive in when there is paralysis of abductors, that is gluteus medius, like in polio or superior gluteal nerve injury, dislocation of hip, fracture neck femur, destruction of head like Perthes disease or avascular necrosis, and coxa vara, when there is decrease in neck shaft angle. So, the angle on which lever arm is acting will be decreased. In that case also, this test will be positive. Okay. So now we'll start with next MCQ. A patient presents with pain in right wrist with gradually enlarging swelling. The X-ray is showing the following picture. Yes, what is the diagnosis? Yes, Dhritarashtra beta, anyone? Dhritarashtra is saying C. Riya Verma is saying C. Okay, beta. That is why I have kept this portion, beta, because in my lecture, at start of my lecture, someone is saying D. At the start of my lecture, I have already mentioned these are the MCQs where we are always getting confused. No matter how many times we are attempting, we are getting confused. That is why I have kept this portion. Okay. So Sarath is saying D. Okay, beta. Now I will tell you. In all my lectures, I am telling you, whenever you are getting image-based MCQ or clinical scenario MCQ on bone tumor, you should first write down two things which are very, very important. More than 90% of the MCQs, clinical or image-based, You will be able to solve with these information only: age and location of the tumor, whether it is metaphyseal, diaphyseal. Now age is not given in the question. Now see, you can see open physis. Physeal plate is open. Here you can see growth plate is open. That means it is immature skeleton. Growth is still not complete. So the patient is in first 2 decade of life. Growth is not complete. Now location, you can see this is epiphysis and this is growth plate, physis or growth plate. You can see now this growth is below the physis in metaphyseal area. Metaphyseal area. Okay. So growth is metaphysis. Okay. So if examiner is not giving you the age group, you can see for this physis. In immature skeleton, you will see this growth plate or physis open, whereas in mature skeleton, you will not find this growth plate. It will be fused. Now you see each option one by one. Chondroblastoma. Yes, age group is immature, but it is epiphyseal tumor. No seen in metaphysis. Giant cell tumor, here the age as well as location is not matching. Giant cell tumor 20 to 40 years of age and epiphyseal tumor. Now aneurysmal bone cyst and simple bone cyst, both are seen in immature skeleton and both are metaphyseal tumor. So what is the difference between these two? Here you can see expansile lesion. This is width of growth plate. This is the width of the tumor. So the tumor is expanding. So this is expansile lesion, whereas simple bone cyst or solitary bone cyst, non-expansile lesion. In simple bone cyst, the width of the tumor will be less than or equal to the width of growth plate, not more than that. So that is non-expansile. So we are remaining with aneurysmal bone cyst, which is the answer here. Now, why I have kept this question here? Because this tumor, as most of you have attempted it like giant cell tumor, because there are septation. What happens in aneurysmal bone cyst? There are blood filled spaces. So due to these trabeculae or septation, it looks like loculated appearance, which may be similar looking like soap bubble appearance. So how will you differentiate? So here is the differentiation. I am always telling age and location. Look for age and location. Now here you can see there is no growth plate, no physis. No growth plate, no physis. So mature skeleton. Now tumor is at distal and radius just below joint line. Yes, Ria beta, I am telling you. Here you can see in this image. Okay. Now you can see here it is fused. That means it is mature skeleton, more than 20 years. And here the tumor is in epiphyseal location. And typical soap bubble appearance. So this is giant cell tumor. Now how will you differentiate from ABC? Here you can see physis is open. Growth plate. So it is immature skeleton. Further, this is epiphysis, this is growth plate or physis, and this is metaphysis. So this is metaphyseal tumor, immature metaphyseal. So both are similarly looking. You can see soap bubble appearance like appearance in aneurysmal bone cyst also. But the age and the location of tumor you can easily differentiate. It is very simple. Remember these two things, age and location. Okay, Dhritarashtra, very good beta. Yes, whatever mistakes you want to do, you do it here only. So you can learn from your mistakes, but don't repeat those mistakes in your exam. Okay. So now clear to everyone. Okay. Now how will we differentiate between aneurysmal bone cyst and simple bone cyst? So this is aneurysmal bone cyst. You see the width of the growth, width of the tumor. Here width of the physis. Aneurysmal bone cyst will always be expansile lesion. That is why the name given aneurysmal bone cyst. It is expanding like an aneurysm of a vessel. Okay. This is simple bone cyst. Here width of the tumor will always be less than or equal to the width of growth plate, non-expansile. Further, in aneurysmal bone cyst, you will find this loculated appearance. Okay, septation will be there. Whereas in simple bone cyst, there will be single cavity. That is why it is known as unicameral bone cyst, single cavity. Okay, and here you can see this fallen fragment sign. Break in cortex, it is falling down, fallen fragment sign, and if it is not falling down, it is hinged fragment sign or trap door sign. So this is the differentiation between aneurysmal bone cyst and simple bone cyst. Now finally the last option was chondroblastoma. So chondroblastoma will also be seen in immature skeleton, physis open, and it will be in the epiphysis, not in metaphysis. Okay, beta, if any one of you have any query, you can ask me. I will clear doubts. Then we will go ahead with the next MCQ, or should we proceed? Okay. Okay, beta. So the given image is showing active sensor, Lesigue sign, Schobas test, Genslen test. Yes, Riya, Medic, Harpreet, Sarad, Samar, Dhritarashtra beta. Karthik is saying C. Yes, anyone else? Okay, beta. So here, some of you may get confused with active straight leg. Pooja is saying C. Okay, beta. So this test you can see here. I think here in this area my picture is coming, but you can clearly see this area. You can clearly see this area. The clinician is raising the leg and doing dorsiflexion of the ankle. So this is passive straight leg raising test, not active straight leg raising test. Yes, definite beta. Very good. Very good, definite. Very good beta. So this is passive straight leg raising test because clinician is elevating the limb and clinician is doing dorsiflexion of ankle, that is known as Lesigue sign. Then for prolapse intervertebral disc. Okay. So active SLR, remember, where we ask the patient to elevate the limb, not by clinician. In active SLR, we do this test for pathologies around hip joints, like fracture neck femur. We ask the patient to elevate the limb by patient, him or herself. Patient is not able to elevate the limb. Patient is not able to do active SLR. So that is active SLR. And yes, very good, definite beta, very good. So that is for hip pathology. Here we are doing for prolapse intervertebral disc, where we do passive SLR. So this test is passive straight leg raising test, where the clinician is doing dorsiflexion of the ankle, that is to elicit Lesigue sign. So in prolapse intervertebral disc, we do two tests. The most commonly done test is straight leg raising test, that is passive straight leg raising test, where clinician raises the limb of the patient in supine position with extended knee. If patient is having similar pain between the range of 30 to 70 degree of elevation, that means the test is positive. To increase the sensitivity of test, we can try to do dorsiflexion of the ankle to elicit the symptoms. Okay, so that is known as Lessigue's sign. Now this Lessigue sign we do in passive straight leg raising test. Now this Lessigue test, which is the other test for prolapse intervertebral disc, is the different test, which is a modification of passive straight leg raising test. In contrast to passive SLR, where we do in extended position of knee, here in Lessigue test we do in flex position of knee and hip, and then we start extending the knee. Okay, so we do passive SLR and Lessigue's test, and in passive SLR, if we do dorsiflexion of ankle, it is Lessigue's sign. Okay, so Lessigue test is different, Lessigue's sign is different. Okay, but both are for passive straight leg raising test. Okay, beta, clear to everyone? Okay, so next MCQ will move ahead. A 20 years old lady presented with wrist pain. X-ray wrist is showing lytic eccentric lesion in lower end of radius with soap bubble appearance. What is the next step for the management? Yes, beta. Dhritarashtra is saying A. Fani is saying A. Anyone else, beta? Ramya Sethi is saying D. Dharmendra is saying A. Boy Good is saying D. Definitely Singh is saying D. Okay, beta. Once again, I am telling why I have kept this question, because we are always getting confused. So, first, I will tell you the answer. Karthik is saying D. Definitely is saying D. Answer here is MRI. So, any bone tumor patient coming to you, first you will have clinical examination, suspected case of bone tumor. Very good, Riya beta. Boy, very good beta. Okay. After clinical examination, first investigation always will be X-ray. After X-ray, the next investigation in bone tumor most of the time is MRI. And once we do MRI, then confirmation of bone tumor by bone biopsy or biopsy of the lesion. Sometimes we can take from soft tissue also if tumor is expanding in soft tissue. After confirming histopathological diagnosis, only we can give treatment. Okay, so before biopsy we cannot give treatment. Biopsy is the diagnostic procedure of choice. These beta, these features are these features are suggestive of the tumor, not confirmatory. Confirmation is only by biopsy. Okay, all radiological investigation, they cannot confirm the diagnosis of bone tumor. They can only suggest the diagnosis. Clear the rest? So now you will ask me, yes, Riya beta. So now you will ask me, if biopsy is confirming the diagnosis, why we do MRI? So what is the role of MRI? Okay, so role of MRI, it helps to suggest the best site of biopsy. Okay, which is the most active site of tumor that you come to know on MRI. Then you can plan that you will have to take biopsy from that side. Second, path of biopsy. MRI will show you neurovascular bundles and their relation to the tumor. And whenever you are taking biopsy, you will avoid that path because you don't want to damage neurovascular bundle. So MRI will help you to properly plan the biopsy. That is why before biopsy we do MRI most of the time in most of the tumor. Okay. So first clinical examination, then X-ray, then MRI, then bone biopsy, finally the treatment. Here X-ray is already done. So next investigation will be MRI. Okay, clear to everyone, beta? Okay. So now you tell me if I change the question. See, similarly, the same question examiner will ask is the okay, beta, if I choose what is the treatment of choice, that means no, beta, the treatment is extended curata. Yes, Farna beta, very good, Farna beta. Treatment, as you know, the suggestive diagnosis is giant cell tumor. So treatment of choice for giant cell tumor as a single best option is extended curettage with phenol along with bone grafting. Okay. Now instead of phenol, we more commonly use liquid nitrogen. Okay. So extended curettage with phenol and bone grafting, it is the single best option for the treatment of choice for giant cell tumor. Okay. Now quickly I will give you a recap of treatment of choice for important tumors. So just mark that up. For giant cell tumor, aneurysmal bone cyst, chondroblastoma, and chondroma. Pardon me, beta, my handwriting is very bad. It is not as good as it should be. So, giant cell tumor, aneurysmal. Okay, Akash is saying voice is not clear. Giant cell tumor, aneurysmal bone cyst, chondroblastoma, and chondroma. Treatment of choice is extended curettage. I think, yeah, my handwriting and this, my pen tab is creating problem. Okay, now it is clear, beta. So, giant cell tumor, osteochondroma. It is excision of the tumor, extraperiosteal excision of the tumor. For osteoid osteoma, radiofrequency ablation of the tumor. For simple bone cyst in upper limb, it is aspiration of aspiration of cystic fluid plus injection, either sclerosing agent or steroids or bone marrow aspirate. If it is in lower limb, simple bone cyst, treatment is simple curettage. Okay, simple curettage. Treatment of choice for multiple myeloma, chemotherapy. Okay, so these are the important treatments of choice, single best treatment of choice for important bone tumors. Okay, so if any one of you have any query, you can ask me, beta, then I'll finish my lectures. Any query regarding orthopedics, regarding your preparation, you can ask me, beta. Okay, so I'll finish my lecture here, beta. Thank you very much, all of you, for joining the lecture, beta. Best of luck for your preparation. Stay safe, stay healthy, beta. Good luck once again for your preparation. Welcome here, beta. Welcome.